Where's this from? Exactly. All right, so let me tell you a story. It's a story of a physician who is collateral damage from the opioid crisis. And specifically, we're going to talk a lot about the Death Certificate Project today. This physician is a family practice physician in a large multi-specialty group here in Southern California. He's been practicing for many years, treats a population or patient population that contains many HIV, people living with HIV. He goes down to Mexico and works down there at a clinic that he funds and to help folks who don't have access to health care down there. His patients love him. As I think I said, he's been doing this for many years, probably 20, 25 years, and no problems, no lawsuits, nothing with the medical board or anything. One of his patients is a woman who struggles with intractable chronic pain. She's also a violinist, a concert violinist, and over time, she just became more and more unable to do her violin playing, loving husband with her as well, and she became more and more depressed and everything, and you can imagine she ultimately commits suicide using some opioids that had been prescribed to her for her chronic pain. The medical examiner's office in this county that this person or this doctor was practicing in referred the case over, saw it was an opioid overdose, referred the case over to the medical board under the Death Certificate Project. The medical board investigated, looked at cures, saw 3 other patients in addition to her who were getting relatively high doses of opioids from this doctor and initiated an investigation not just about the patient who died, but also about the 3 other patients. They sent him a letter, they interviewed him, and then they issued an accusation, a 60-some page accusation against him to ostensibly revoke his license. And that's still pending. He hasn't gone to hearing on that. Well, what has happened, in addition to him suffering the embarrassment of a public accusation that all his colleagues know about, is that the carriers, like the Blue Crosses, the Cignas, have also taken him off their panel. He can't prescribe. He can't see their patients anymore. So let's say you lost United Health, Cigna, and Blue Shield. How would you be doing? Pretty good, huh? Essentially, they've de facto taken away his license. That's what's happening under the Death Certificate Project these days. We're going to talk about some of the legal aspects of the Death Certificate Project. Neither Taryn nor I are doctors. We're both lawyers. We have JDs behind our name, not MD. We're going to talk about the history of the board's response to opioid prescribing and then ultimately the creation of the Death Certificate Project. We're going to talk about a couple real cases like the one I just talked about, as well as a hypothetical case that Taryn's going to go through with you, and the medical board's approach to those cases. And then what steps you're to take if you get an investigation letter, and what to expect if you do get that investigation letter. And I'm sorry if you do. I'm just sorry. This is not going to be a bright and sunny lecture. It is the exact opposite of the weather outside. This is going to be a kind of a gloom and doom lecture. You guys are under the gun. This Death Certificate Project is absolutely an attempt to scare you out of prescribing opioids. It's an attack on the supply side, and I don't care how the medical board phrases it, that's exactly what it is. It is an assault on you folks. Taryn's going to talk next about some of the history of the medical board response.
Thank you, Chris. As Chris said, this is sort of a doom and gloom lecture, but hopefully we can give you the information here to help you guys prescribe in the best way possible that will conform with the new guidelines and upcoming laws. So as you can see here, there's quite the history of prescribing. In the late 90s, the American Pain Society launched their campaign that pain is a fifth vital sign. Also around this time, I'm sure as everybody here knows, there's national groups unrealistically recommending a getting to zero pain. It's just really not feasible to do that for these types of patients with chronic pain and illnesses, things like that. Also, pharmaceutical companies, I'm sure as we all know, develop stronger and long-acting opioids with aggressive marketing to physicians that help play a role in the history of opioid prescribing and why we're in the situation that we're in today. Along those same lines, pill mill practices started coming up all across the US, also contributed to this problem. And unfortunately, from 2000 to 2014, the rate of opioid sales has greatly increased, resulting in a quadruple opioid overdoses in that span of time. So we are in a bit of a crisis, and we have been since the late 90s, early 2000s, and that's the reason why the medical board is doing what they're doing, but unfortunately physicians are getting the brunt end of the stick, as we'll continue to talk about. So in 2007, the medical board issued these guidelines. This is obviously a synopsis of what they indicate that physicians should do. Of course, history and physical, treatment plan objectives, so on and so forth. But unfortunately, in the cases that we've been seeing, the medical board is targeting physicians prescribing during the time frame 2009, 2010, 2011. However, the next set of guidelines come out in 2014. As you can see in a comparison, the 2014 guidelines are quite extensive. And just for reference, I was actually able to get a copy of the 2007 guidelines from the Medical Board of California, and they're 5 pages long. The 2014 guidelines are 90 pages long. So unfortunately for you guys, they're holding you to the 2014 guideline even when you were prescribing in 2009, 2010, 2011. It's very unfair to these physicians, as you guys know, to hold them accountable to something that we didn't know was in existence, and it's really unfortunate to see. So in 2014, this is the guideline that we're following right now in 2019. History and physical exam, consultation, treatment plans and objectives, patient consent, pain management agreements, counseling patients on the risks and responses, opioid trials, compliance monitoring, of course, cures, and accurate record keeping. Another thing I want to go over in this specific slide here is that when you perform your history and physical exam, it's also important that you are documenting that you're examining whatever issue that the patient has in regards to their pain. So say you have a patient that comes in with chronic back pain. You need to document now that you actually examine their low back and it's abnormal. And so that's why you're prescribing these kinds of medications. It's not enough anymore to just say that they have low chronic back pain and without physically documenting that you're examining whatever area that they're complaining of. So the medical board prescribing guidelines in regards to taper doesn't really give you a lot, unfortunately. But I was able to find a case, or I guess a hypothetical, of what they would like you to do. If you could bear with me while I read it off. This is a hypothetical example of what they would like physicians to do when a patient like this is seen. A 50-year-old athletic woman sustained an injury while snow skiing, resulting in pain in the distal lateral aspect of the left knee that she prescribed as 10 out of 10 pain. Within 2 hours of the injury, the patient was evaluated, which included a thorough history, examination, and x-rays that confirmed a small fracture. The patient had no history of substance abuse. She was prescribed hydrocodone to be used every 6 hours for severe pain, and then ice on and off. A knee brace, crutches, or a cane as tolerated, and phone advice from orthopedics. Within 48 hours, after taking a total of 5 opioid tablets, the patient limped with a cane, and the pain level ranged from 5 to 7. As advised, the patient changed her medication to over-the-counter non-steroid anti-inflammatory drugs. Physical therapy was started to assist further rehabilitation after 2 weeks, and the remaining hydrocodone tablets were appropriately destroyed. So the medical board says that this case exemplifies the appropriate evaluation and management, including low-dose, short-course opioids, alternative pharmaceutical and non-pharmaceutical management, and the destruction of leftover opioids. So this is an example of what the medical board wants to see in regards to patients that are prescribing opioids. The CDC also came out with guidelines in 2016 that pretty much correlate with the medical board guidelines. A quick summary of these is avoiding prescribing opioids at all costs if you can. However, it's difficult, right? Because a patient comes to you and they say, I have fibromyalgia, and my pain is 15 out of 10. You have no choice but to take them at their word, and so it's difficult for physicians to, comport with that. The next thing that they would like to see is screening for mental health issues, to discuss the risks and benefits of opioids with the patients and prescribing that, and documenting that you had these conversations. We have a different case right now where the interviewer, where it was asked of a physician, did you document that you had these conversations? And he didn't. He did not document that he had this conversation, but it's his custom and practice to do that. And that's fine, and at the time he was taken at his word, but sometimes that's not going to be enough for you to just say that, yes, I do this, but it's not written down. The medical record as Chris and I, from our perspective and the medical board's perspective too, is a legal document. So if it's in there or it's not in there, we can't prove or disprove that it didn't happen. So it's very important, and I know it's difficult with documenting to be so specific. You don't have a lot of time with these patients, but in these types of cases, it's really something that could make or break your practice. The next thing that they want to ensure physicians are doing is avoiding prescribing more than 90 morphine equivalents. They would really like to see physicians utilizing urine drug testing, of course, consulting with cures, as we'll discuss in a little bit, and avoid the combination of benzos and opioids.
All right, so what is the Death Certificate Project? It's a project that was launched by the Medical Board in 2015, and it was obviously designed to address the opioid crisis on the supply side, as I discussed before. It's a project where if a medical examiner thinks or determines that a patient who had a prescription for opioids died of an opioid overdose, even if it wasn't from the prescription opioids, maybe it was fentanyl they got on the street, have that case. They are still going to send it over to the medical board for review. The medical board then has its reviewers. Does anybody do reviews in here for the medical board? Really? Nobody? Good. They only pay $150 an hour for the reviews. That's way too low for all you folks. And also now I can badmouth the reviewers. But so they have it reviewed by usually a medical doctor and also a former law enforcement officer. Those are the investigators. And that, we'll talk later about when you're contacted by the medical board. The former law enforcement officer is the guy who's going to be contacting you. They're not the sharpest tool in the shed, but don't let that fool you. I'll talk more about that later. They look at the case and they determine whether or not there was any kind of excessive prescribing. They will look at cures. Remember I told you about Dr. Jed in the beginning from Beverly Hills, or not from Beverly Hills, but the Beverly Hillbillies, who they went in and said, oh, we had this one patient who died. Look, there's 3 others that looked like they may have been getting excessive opioids. Maybe those patients are getting prescriptions from different providers. That's the one, the doctor shopping. You guys have heard about that. They can detect that on cures, as you know. In any event, if they see any kind of excessive activity that they think is excessive by the physician, then they will send the physician a letter saying, we'd like to discuss these patients with you. Sometimes that letter will say, send us a written response to kind of our allegations here, and sometimes they'll skip right to the interview stage. Once they do the interviews, if they do an interview with you, and we'll talk more about this, they'll send it to additional reviewers who will recommend whether or not there should be any accusation issued. They'll issue an accusation, and from that point on, you're going to get to know your lawyers very well. And what happens when you're identified is kind of what I just described. Once it gets into the accusation and the whole process with the medical board, it's just as though you had some other medical board problem, inappropriate touching with patients or something like that. It's a regular medical board case at that point. Just some statistics. I'm not going to read over them on the right, but just see how many, 26 or 2,700 death certificates reviewed by the medical board since 2015, and 522 prescribers warranted investigation. Almost all of them were MDs, and 234 cases, it feels like there's more, but 234 cases await review or are in the process of going through the whole medical board adjudication process. By the way, which, as I think you guys know, that can end in you losing your license. Normally doesn't, but it can. Just some, let's see if I can get yeah. So this is, if you guys can't see this line, these are the number of opioid-related deaths, overdose deaths in California from 99 through 16. You can see the kind of the rise as Purdue got their marketing efforts going. And you can see that there is a bubble here in the number of deaths in California. And just from my perspective, doing both this and medical malpractice work, I read a lot of medical records, you can imagine. This is the kind of the sense I get was kind of the peak of the prescribing of opioids. So I did some quick and dirty research, and yes, this coincides roughly with the peak of prescribing of the oxys. Another interesting part about this graph here is you see that we are having some success in reducing the number of opioid prescription deaths in California. Is down here by 2016. We don't have the data for 17 and 18 yet. But the other thing you can see as those go down, look what goes up. Synthetic opioids and heroin. So we're talking about the fentanyl, right? That's what's killing a lot of these people is the fentanyl because they don't know how to dose fentanyl. They're not an anesthesiologist. And so that's what we're seeing. As they can't get it as much in the doctors, from doctors, they get it from the street. And by the way, the other thing, I just saw a story yesterday in the paper. Apparently, on the black market, they're taking pills, they're making pills that they're telling people are oxy. They're actually fentanyl. Would that have any effect? I don't know. I'm not a doctor. Is that a good thing or I don't know? So what's the problems? What are some of the problems with the death certificate program? We touched on some of these a little bit. If you can't read it, clinicians take over patients. You guys have taken over patients from other clinicians, right? And sometimes those patients are already on relatively high-dose opioid regimens. Well, guess what? If that patient dies while you're caring for that patient, are they going to go back? Are they going to go after Dr. A or Dr. B? You, Dr. B. They are almost certainly not going after Dr. A. So that's a problem. So what do? You can't just, when they come to see you, you can't just, well, I'm going to stop you. I know you've been taking a lot of opioids, but we're just going to stop. That's, cutting it off cutting off patients' opioid is a safety issue, right? Am I wrong about that? I'm wrong? So you would do it?
I'm not saying I would do it, but there are only 2 life-threatening withdrawals.
I think benzo.
And what happens? We haven't done your
one.
Yeah. What benzo's? Well, what happens then when they are in intractable pain? Taryn's going to do a couple of case study a little later on, and we saw a patient that was kind of on that hard line, cutting patient off. Guess what they did? Started drinking and committed suicide. So the psychological effects, at least. Another one, physician flight. Some of you maybe even thought of this. I'm done. I'm not even going to see these kind of patients. I don't need this headache. I've heard that from lots of different physicians, primary care physicians. That it's just not worth it to them anymore. But then what do we have? We have patients out there who need care who aren't getting care if they're kicked out of practice. Also, as Taryn mentioned earlier, we haven't been able to prove it. The lawyer community yet. We haven't been able to prove it yet. But we think that what's happening is the medical board is applying standards that are in place now to patient care that was rendered 6, 7 years ago. There's been a change, as you know. I think there has, right? Has there been a change in the way we look at opioid prescribing over the past 6 or 7 years? Something you may not have done, you may not do now. You may have felt okay doing back in 2011, 2012. So. Here's the tale of 2 doctors.
So this is a hypothetical that I'm going to pose to you guys. So Sue comes to see you, 2012. She's in a bad car accident, chronic back pain, unable to work. Her pain is 7 out of 10, often all the way up 10 out of 10. She has anxiety, insomnia. Her meds help a little bit. She's always kept her appointments, no aberrant behaviors. She's on Medi-Cal. So these are all the medications that she's on, morphine, Valium, Ambien, etc. Her assessment, opioid dependence, anxiety, and she's on benzos. So what are we going to do with Sue? If she comes to see you, let's say that you want to refer her to a specialist. So depending on where you are, you have 2 specialists in your area. The first one doesn't see patients like Sue because she's on Medi-Cal. Okay? The next one already saw Sue and recommended an increase in her opioid dose. So again, this is 2012, so we're going to maybe consult some medical education and literature. But again, at the time, there's not much there for you. So let's review her pain. She says that every time she's laying on a dose, she has severe anxiety and withdrawal symptoms. She cannot function without her medications. She tried to taper herself, but fell apart and considered suicide. She barely functions on her current dose as it is. She's never shown any signs of addiction. Except the previous ones, right? So Sue says. All right, so let's say that Sue goes to Dr. A. Dr. A is uncomfortable with the dose increase recommended by the specialist. I'm sure as many of you would be as well. So Dr. A goes to some CME course, and he learned that he should rotate Sue to methadone, advising Sue to start on 1/3 of the calculated dose every 8 hours for breakthrough pain. Sue is very anxious about this switch. She, as we know, already has a history of anxiety. So Dr. A kept her on Valium with plans to taper. Okay. So let's say Sue goes to see Dr. B. Dr. B believes that Sue's pain is due to opioids. So she decides to work with her to taper the patient. Great, perfect. She starts with recommending a 5 to 10% taper per month, starting with the opioids, and then to do the benzos later. After a lot of difficulty, Sue is down, but she's still taking Valium and Ambien. Okay? So the outcomes for Dr. A, Sue passes away from an overdose within 2 weeks of starting methadone. Dr. A believed that the dose accumulated and caused her overdose. He's devastated and doesn't know what he did wrong because he followed the education that he received at the time, taught by that CME class. With Dr. B, she continued to taper Sue and pushed her probably too far. Sue died within 3 months. Her family stated she'd become increasingly depressed, started drinking, and they suspect this is a suicide. So now, in 2019, both doctors received a letter from the medical board evidencing that they had a problem with their care and treatment of Sue. So Dr. A gets this letter, and he says that he doesn't even want to do this anymore. He doesn't want to put his license at risk. He tells his patients on high doses that he will start an aggressive tapering program 10% per week, which is exactly what Dr. B did in the previous slide, and his patient commits suicide. So he says, I can't be responsible for what they do on the street, but I can't prescribe doses anymore and put myself at risk. Dr. B says she tells her patients she's sorry, but she's no longer going to treat them for opioid pain. Throws her hands up. She did everything she could with Sue, and she died anyways, and she doesn't want to risk it anymore. So what should we do with, what should doctors do with patients like Sue today? Ideally, the guidelines say that we should follow them, as closely as we can. Refer Sue to a specialist if there is one available, and review the medical education and literature. Well, again, in 2012, some of those things weren't available. Hopefully now in 2019, all these things are going to be more readily available to physicians so that you can comply within the guidelines. Again, be sure to utilize risk screening measures, urine toxicology, cures, and pain management agreements. So one quick thing I'll say about pain management agreements is it's great for your patients to sign them, every year or so, but it's a whole other thing for them to actually abide by the agreement. So we have a doctor also who had his patients sign pain management agreements, but even when his patients were not following it, he did not discharge them. So of course, we're all physicians, we want to help these patients as much as possible to get them the best care and treatment. But if they're not abiding by their agreement, it's a risk on you. And I think it's very important to reiterate that to you guys, because as much as you want to care for them, there has to be some kind of hard line. If they're constantly, getting their medications early, if they're giving you a call that they're in all this pain, if they're, having these types of aberrant behaviors, it's really something that you need to do a risk-benefit analysis on how else you're going to help this patient, or maybe discharge them to a different physician if another physician is willing to take them. But it's, like I said, one thing to actually have them sign the pain management agreement, but then they also need to follow it. As I'm sure you guys know, it's so important to document. Treatment plan, objective goals, improvements, and setbacks is what the medical board wants to see in all the medical records of these patients who are being prescribed opioids.
Thank you very much. So there have been a couple new laws come out. I'm pretty sure you guys are aware of them, but I just want to go over them real quick so that we're positive that you're aware of them. October 2nd, 2018, a law, and it was, in case you guys are any lawyers out there, SB 482. It says that you're now required to consult cures when first time you're prescribing to a patient. You have to do that within the 24-hour period before prescribing, which means while they're in your office, right? I mean, within 24 hours before prescribing. If there's exemptions to the checking of cures, and if they come to you with a controlled substance prescription, say they were seen in the emergency room and they're following up with you for, I don't know, the knee injury or whatever it was, and you're going to go ahead and keep them on opiates for a little while longer for pain or whatever, then you may, that's actually probably not a great example, but just if they come to you with a prescription that was exempt previously, then you need to check cures again. So I would say anytime you're first time prescribing opioids to anyone, check cures. I mean, it's a lot easier now than it was, right? Yeah, good. I understand that you guys, it's like a couple clicks on your computer, so that's great. It wasn't like that, remember, years ago. And that's a defense, by the way, that a lot of doctors are using, that, you can't, back in 2012, do you know how hard it was to check cures? And, the medical board, they're not reasonable.
Yeah,
They're not reasonable. They think you have all the time in the day to be, getting your IT people in there to help you and all that kind of stuff. It's unfortunate, but again, remember, our lecture is gloom and doom today. Once they're on the opioids, if they're going to continue with it, you have to check cures every 4 months to see if they're doing any doctor shopping. Or I think I may or may not have mentioned, but we have one case where it looks like the guy was getting a paper prescription and he was somehow copying it or using a high quality scanner to make 2 of them. And then he would go to 2 different pharmacies. Now, why the pharmacy wasn't catching this, why they weren't checking cures, but that's what it looks like. We're still investigating. So what are the exceptions or exemptions from consulting cures? You guys probably don't treat a lot of patients. Maybe some of you guys do take shifts in the emergency room, but if they're coming to the ER or if they're an inpatient. Basically, if they're getting a prescription as an inpatient, you don't need to check cures. If it's part of the treatment for a surgical procedure, so arguably, well, I guess that patient with the knee pain didn't have surgery. But if it's a short course after surgery, it's going to be a real short deal. You don't have to check cures, but why not? Why not? Because that might give you some data and say, oh, wait a minute. This patient didn't tell me they already had an opioid prescription from some other provider before they came to me. I better be careful, even if I'm just given, 10 tablets or something. And if the patient is in hospice care, you don't need to worry about it. There's a lot of the pain, cancer patients, especially in hospice care, a lot of the stuff's out the window. They want you to just try to make them as comfortable as possible. Except with regard to naloxone, which I'll talk in a second, which I'll tell you about in just a second. But you guys, I know you know about this, because I guess Danielle's done a presentation on this for you, so we won't go as deeply into it as she did. But effective beginning of this year, just a week or so ago, you have to offer naloxone to patients when you're prescribing opioids, basically. And if the prescription dosage is 90 morphine equivalents or greater, if there's an opioid, a benzodiazepine prescribed concurrently. This is a big deal to the medical board. That all the cases that I have on the death certificate project involve co-prescription of opioids and benzodiazepines. And then there's a third one. Have you guys heard about this Holy Trinity? You guys know? Anybody know what the Holy Trinity is? Does anybody? I know the Holy Trinity. But the Holy Trinity of drugs includes opioid, benzodiazepine, and soma. Yeah, so I guess that combination produces some incredible high for them or something like that. And it's also, can be lethal. Oh, and the other one, this just came out, a little, I guess you call it a FAQ response from the medical board, just came out on another situation where you need to be thinking about offering a naloxone prescription. And that is if you have a patient who you, in your clinical judgment, and I personally, and this is just me, but personally, anything in your clinical judgment that you think this person might be at an increased risk for overdose, I would maybe say that these are patients that have a history of substance abuse. Maybe they've been sober for 20 years, but you're not sure. Maybe, I don't know, somebody that might not be able, that you think might have some mental issues where they might not be able to control the amount of their medications they're taking. Maybe they take one and forget about it and take another one, and next thing you know, the ambulance is on the way. So anytime in your professional judgment you feel like there's an increased risk for overdose, go ahead and offer the prescription. They don't have to fill it. You offer the prescription to them. You can even just send in the prescription. Unfortunately, I understand we looked today, and I think it's about $200 or so for the naloxone. So I'm sure a lot of your patients have $200 lying around that they just love to spend on this. You think it's different? Oh, great, great. Then our information's wrong. Okay, okay, that's great. I'm glad to hear that. You want to say something? No. Okay, good. I was outraged when I saw that. It reminded me of the EpiPen thing. So I forgot where I was at now.
Question. Chris, there's a question.
Yes, I'm sorry. Yeah, yes. Look, offer it. What's the problem? Hey, I think it's a good idea. And oh, by the way, have anybody here has been offering naloxone? Yes? How do the patients take that? Yeah. The first time I heard about this was a doctor telling me, you wouldn't guess what just happened to me. My patient just stormed out of my office. What do you want me to do? But again, they don't have to take it. You just have to offer it. And a question that kind of came up in our discussions was how often do you have to offer it? I would say, you know what, remember that cures law? It says every 4 months? Why don't you just go by that? Just say, hey, I was just trying to go by the medical board guidelines and the law. Just offer it again and document that you offered it. Document, document, document. Because good documentation can stop you from getting to the point of having to go for an interview with the medical board. Sir, doctor. I would not, this law is so new that I would say err on the side of caution and just offer it.
Mm-hmm.
Not that I'm aware of. Not that I'm aware of. So how does the medical board view this law? It applies in any ambulatory setting. It does not exempt hospice patients. So if that cancer patient in hospice with extreme pain is getting opioids, they need to be offered naloxone. And it's not actually limited to those who just prescribe it, any licensed provider. So if someone else has prescribed opioids and maybe they did or did not offer naloxone, and this patient comes to you, maybe it's their pain management specialist, you probably should offer naloxone anyway, even though you might not be the one prescribing the opioids, for instance. That's what that means. Does anybody else see a problem with this law, though? What do you mean? Like, oh, so you'll experiment with how far you can go if the patient...
It's just another reason for them to take you down.
Oh, yeah, the medical board. Yeah, good point. What happens when somebody overdoses on opioids? I'm not a clinician. Let me know. What does it look like? Okay, so how can they inject the naloxone? That's a problem. I'd recommend that what you do is you try to talk to them about, hey, who's there? You have a roommate, you have a spouse or somebody that can administer this. You can't prescribe it to the spouse for that person, right? Because that person wouldn't be your patient. So I would recommend a discussion about that, because you can give them naloxone. If they live alone and they're taking it, it's not going to do any good. But at least you're covered because you gave it to them, you gave them the prescription. Yeah, I know. I don't make the laws, I just talk about them.
And you documented it.
Yes, yeah, that's right. Yes, ma'am. Well, that's right. It doesn't say. The law doesn't say. But what I said was, listen, my recommendation would be, remember the cures every 4 months? Every 4 months or every 6 months. Just all it is a discussion. Offer them. Once you've done it once, they're not going to get mad the second time, right? I don't think. Maybe you guys know better. Yes. I mean, I know more documentation is the bane of your existence, but patient offered naloxone as well.
Yeah.
Add that to the bottom line. What happens if you don't offer naloxone and let's say the patient passes away? That the prescriber must be referred to the medical board for administrative sanctions. Now, this is not like where hospitals have to contact the Joint Commission when there's a certain event that occurs, or CDPH. Memorial Care is not right now referring people to the medical board for failing to prescribe naloxone. That's per Danielle. But if you don't do it, and not if there's not if they found out somehow you didn't do it, and there wasn't an issue with opioids, this patient some way other way the medical board got a hold of this patient's records and they found out, they would open an investigation against you based on this law. Let's say that patient did die, and let's say the family decides to bring a wrongful death case against you for that prescribing. It happens. Absolutely happens. Big problem. And if I was defending you in the medical malpractice case, I would start with one hand tied behind my back, because there's something called negligence per se, and that is where you violate a law, and during the course of that violation, you may or may not have been negligent. Well, the law says, negligence per se says, you were negligent. So now we start your medical malpractice case with you not having given or offered naloxone to the patient, and we start with a presumption that you were negligent. How do you like that in a medical malpractice case? Sounds fun, doesn't it? All right. So what's it look like? We've talked a little bit about this already, but you're going to get a letter. I hope none of this happens. you may get a letter from the medical board after your patient has passed away. It'll be some months or even a couple years afterwards. Excuse me. And first thing you want to do is let your risk management staff know about this. Don't keep it private, please. It's really important that they get involved because they can assist you with certain aspects of how to respond to this. They can help you get counsel involved, which is the next most important thing. Don't wait. Listen, don't wait until you're called in for an interview to contact counsel. Don't wait until you get an accusation to contact counsel. You absolutely have to contact counsel. And please, at the very earliest stage possible. And please, when you're you often can choose. It's often not from the panel for your medical malpractice carrier, although they can refer you. But don't go to some lawyer who your brother knows who handled his divorce or something, like that. Let's get somebody that has some experience in healthcare and licensing. Very important. Also very important, this is more your lawyer's job. It's something you need to be keyed into as well, because a lot of times, I know when we handle cases, we ask doctors, is there somebody in particular you'd like to review this case, somebody you respect? But your lawyer and you will get together with an expert who is in your field of practice, but who has experience with the medical board. It's a little different animal than the doctors out there, or the cases out there that are reviewed by physicians of medical malpractice cases. Slightly different way that we're handling it. It's a quasi-criminal proceeding versus just a civil proceeding on the medical malpractice side. So what happens normally? You get the letter. The medical board has either gotten your patient's consent to get their records. Sometimes I know of the doctor that has 4 patients under review, only one of them actually consented to their records being given to the medical board. Didn't stop the medical board. They just said, well, forget it. We're going to subpoena them. The investigators I talked about review the medical records. They ask for the physician who's under investigation to explain the care involved. Why did you do this? Explain what was going on here. We're not really sure. If the investigators after that don't find that there's been a breach of the standard of care, that's medical malpractice lingo, what they call it is departures for the standard of care in the medical board side, they'll close the file and you're done. You'll get a letter from them saying, thank you, we're not going to proceed with this. The next route, though, is you go through the writing a letter back, or by the way, they can also short circuit this. In the one with four patients, they didn't do any of the letter stuff. They went right to, we want to interview you. And this is where that investigator right here, that former law enforcement, it's not going to be the MD that looked at your case. It's going to be the former law enforcement investigator. You're going to get on the phone with them, and with all due respect to these folks, they are not sophisticated. And they're going to almost kind of lull you, because they're so not sophisticated, almost kind of try to lull you into thinking, oh, it's just going to be a chat. Come on down. There'll be a doctor there just like you. It'll be fine. It's in the movies where they get them and they have a light and they're shining it on you, for the interrogation. That's really a lot more. It's like even when I've been sitting there next to the doctor. Yes? Yeah. So, I've seen. Yes, I would do this. I would do a couple things. Number one, I would, if your first time impression with this patient and your colleague has been seeing him for a while, colleague has him on opioids, has offered naloxone, and you feel comfortable doing a refill, go ahead and document that you, also I'd like to give you a prescription for naloxone. Is that all right? That kind of thing. And go from there and document that. Then you can do it. Legally you can do it. But if the medical board, I've seen that in the charts from the medical board cases I have. And I haven't seen the medical board go after a physician who is covering and just gives a prescription refill, even when they've seen the patient. Maybe they saw the patient for your colleague.
From what I've seen, it's whoever is the designated PCP is the ones that the medical board will go after.
So, but be careful, because that actually has come up recently in some medical malpractice cases I have, where the prescription's over the phone with multiple providers, and if it was here, they just go after Memorial Care.
Yeah.
So what happens is you get in, they somehow get you in there. Now I hope by the time you get to, hey, we want to talk to you, if you haven't already listened to me and gotten a lawyer involved when they get the letter, don't go to this interview without a lawyer. The lawyer can't do a lot of, or shouldn't be doing a lot of interference during the interview, but the interview itself will be more circumspect in my experience. They'll focus. They won't try to take advantage of your naivete about the process if you have a lawyer there. After the interview, they send the interview transcript records to another reviewer who does it. And by the way, the person asking the questions in the interview is going to be, it's going to be that ex-law enforcement investigator, but then he's going to turn it right over to a experienced doctor who's going to do most of the questioning. So it's not going to be a situation where you can kind of bluff your way through it with a non-medical person. It's going to be a medical person there. And if you try to bluff your way through, it's not going to work. They send everything to another expert reviewer. They look at the records, anything else you provided, the interview transcript. If they don't find a breach after all that, they close the investigation. If they do find a breach of the standard of care, the Attorney General will then have an accusation filed against you, which becomes public record. Insurers, as I told you about before, remember the insurers, they find out about that, they check for this kind of stuff, and it just becomes a world of hurt for you. If they file an accusation against you, if we've gotten this far, if you get an accusation, do not wait to retain counsel. I can't tell you that enough. I've had doctors come to me saying, well, I just got this document in the mail. It looks like they're charging me with a crime or something. I said, well, how did that happen? Did they interview you? Oh, yeah, they interviewed. Well, why didn't you, what? You know, and so, look, this is serious. This is real serious, folks. Then you're going to, unfortunately, I know you're busy, but you're going to need to spend a good amount of time with your expert, and we recommend in person talking about the case and the reasons you did what you did and talking about the documentation. You're going to communicate with your group regarding insurance coverage, and what I mean by that is most professional liability policies have a carve-out for administrative law proceedings like the medical board where there's a certain amount of money that is set aside for you to spend on legal fees, experts, et cetera, like that. So that usually comes, I don't know about your insurance, but it usually comes, yeah, so there you go. And then your lawyer is going to create a dialogue with the Deputy Attorney General's office or the Attorney General's office, not you, and try to see where they're going. Now, interestingly enough, in the most egregious cases that we've seen under the Death Certificate Project, and we haven't seen them all, my firm doesn't have all of them, we have some. The AG actually doesn't start with, we want to revoke your client's license. They actually have started with, well, you know what? It looks like it was good faith prescribing. I mean, if you're in a group like this, you're not running a pill mill, that kind of thing. That's where they would really go after your license. They start with probation. The problem with probation, and this is another new law that goes into effect either June or July. Yeah, June. If you're on probation from the medical board, a couple things happen. Number one, you may have those carriers who didn't already suspend you from their panel and you didn't successfully appeal that, which is hard to do. They may then drop you. So it's like a de facto revocation of your license. And in addition, the new law says you're going to have to tell all your patients before you see them that you're on probation. How does that sound? Yeah. Think the Naloxone prescription turned them on? Okay. Any other questions? Yes, Dr. Israel.
One of the requirements will look like they're diverting.
What I would say to that is look for other, and you're going to document this in the chart, look for other signs that they might be diverting. For instance, are they asking for earlier refill? All the various signs that you know about. And document. The patient indicates, doesn't, use, or, whatever just document that fact in there. That you've checked cures, that you have offered him naloxone. There's only so far you can go, and unfortunately with the hypotheticals, remember though, that doesn't always save you. Even if you follow all their rules, it doesn't always save you.
I mean, do I still do the urine knowing it's going to be negative, or do I document that I'm not doing the urine because I know it's going to be negative?
This is what doctors tell me they hate, and that is the defensive medicine. That's what you're doing. You have to do defensive medicine, even more so than against a medical malpractice case, because medical malpractice cases are about money, ladies and gentlemen. This is about your license.
Yeah. I would say the answer to your question is yes. I would say yes.
Do the urine
Do it.
results,
Do it.
the urine,
Yep.
And then when the results come back negative, I don't tell them to do it again and again and again. Right?
Periodically. How often would
Yeah.
you normally do it?
Well, the law is what, once a year, right?
Yeah, so they do it once a year. Yeah, but keep an eye. I'll be right with you. Keep an eye open though for other diverting. I think the pills are, what are they going for? $8 a piece or more on the street?
I think there are more.
Yeah, so it's a legitimate, very legitimate, that it could be. And the other thing in that situation, I would think, is you're going to do an exam that's going to document that they do in fact have pain, right? And so they have a good faith reason to have the medication still. You know, if they don't have any pain, if their exam's completely normal, but they still are occasionally taking opioids, that's your clinical judgment. So. Yes, sir. Let me tell you, your comment actually brought to mind, we okay? I'll be brief. Brought to mind a story from a case, a criminal matter I handled right when I was getting out of law school. Actually, it was in Orange County. It was an insurance fraud ring. And the Department of Insurance sent investigators in after they were basically dummying up injuries after auto accidents and committing insurance fraud. The doctor asked the investigator, the fraud investigator, are you having any pain? And the fraud investigator said no, and the doctor continued down the line of physical therapy and all that kind of stuff at his office, of course, where the billing was done. If you guys have a patient who says, oh, no, I just want the opioids, or no, I don't have any pain, when they ought to have pain but they still want to get treatment, red flags. Red flags should be going up. So be really careful about that. And the patient was actually wearing a wire, or the investigator was wearing a wire, so all that was on tape.
And furthermore, to your point, just make sure that you document that you're having those conversations with your patient, even if you're having them verbally, and they, tell you they understand. Just make sure that you say, discuss with patient, X, Y, Z, so that it's in the medical record.
Anything else? Yes.
What's the look-back period for what you're saying that they're actually going after?
They can go back 7 years.
7 years.
But what they're doing is they're going back farther than 7 years, and they're just saying in the accusation, but we're only considering, all this other stuff is there, but we're only considering the last 7 years. Yeah, okay, sure.
So it's a long time.
Yeah, 7 years. Medical malpractice is normally 1 year from the date they suspect negligence. There's the difference. All right, folks, I guess that's it. Thank you very much for having us. We appreciate your time.